Okay, welcome everyone. It's great to see a full room again. Last year we had a spillover into another room, so I think another room is available, but if there's any spare seats, then do squish along. So I'm Andrew Sharp, I'm a cardiologist from Cardiff in the United Kingdom, and I've been in this PE space for about 11, 12 years now. And I've been tasked with chairing and just opening up with why do we need new treatment options in PE. We have a stellar panel, and we're going to show you some cases and show you what some of these technologies can do. Those are my conflicts of interest, which include a few companies that make these devices. Okay, so pulmonary embolism. So what is the problem? So this is an astounding paper from Andrew Cohen, who's a researcher from King's College. He looked up all the deaths that were coded as related to VTE, venous thromboembolism, in just 6 countries in the EU in 1 year. And what he found is that VTE diagnosis was made post-mortem on 200,000 patients from 6 countries in 1 year. 126,000 of them experienced a presentation of sudden death. And then the ones who were alive at presentation, 27,000 of them died after presentation to hospital in just 6 countries. This is a massive problem. So there's a joke that goes around PE literature, which is you always have to open with PE is the 3rd commonest cause of cardiovascular death. And you don't really think about it. But that's 27,000 people that could have potentially been saved in just 6 countries in the EU. So you multiply that up to how many there are across Europe, and there's a lot of people dying of venous thromboembolism-related problems. And so you'd think we're getting better at it, right? We're getting better at most things. If you think about some of the other rooms in this place, mortality from TAVI is now 1% in the cath lab. Mortality from STEMI, if you don't have cardiogenic shock, it's now 1-2% in most centers. Yes, cardiogenic shock is still difficult for STEMI because the pathology is difficult to reverse. But with pulmonary embolism, you can reverse the pathology. You've just got to open up that clot. So how are we doing? Well, this was a study from Portugal that tracked over 8 years what was happening with patients with high-risk PE presenting due to shock. And the mortality is 63%. 63%. Cardiogenic shock due to myocardial infarction was about 50-odd% in danger shock, and in some of the US studies is a bit lower, around about 30 to 40%. PE is doing worse than myocardial infarction, and yet we've got the ability to reverse the pathology. You can't do that in myocardial infarction. So we've got to do better on this. So what are we using at the moment? Well, intravenous thrombolysis is the class 1 recommendation in the guidelines, based on a single randomized trial of 8 patients, 4 of whom were randomized to streptokinase, 4 of whom to anticoagulation. The 4 who received anticoagulation died, the 4 who received streptokinase survived. And then observational data was used to pad out the recommendation. And so we give thrombolysis in high-risk PE, or at least we used to. In 2014 in Portugal, if you were a young person under 65, that's the gray bar, then about half of people got lytic, which is about the standard around the world. If you look through registries, about 50-60% of people who have high-risk PE get lytic. But the problem is it's withheld in the rest because everyone's nervous about causing intracranial hemorrhage or causing bleeding-related complications. Plus, the patients who have large PEs, they tend to have cancer, they tend to be old, they're postpartum, they're postoperative, and so they don't get lytic. So we've got this huge gap where here 80% of people aren't getting lytic. And it's associated with a mortality of 63% in a modern country with a good healthcare system like Portugal. So that's high-risk PE. How are we doing? We're doing badly. We need new treatments. Intermediate high risk, I'm sure you've all seen this. That's patients whose blood pressure is preserved, who have some clinical markers of risk as defined by the PESI score, pulmonary embolism severity index, and who have both RV dysfunction, which is usually a CT, but it can be echo, and they have abnormal biomarkers, which is now defined as troponin. BNP used to be in there, that's now been dropped a bit. So it's troponin rise and RV dilatation on CT. That's usually how it's defined, with some clinical risk markers, but not shock, intermediate high-risk PE. And so how sick are these patients? Well, if you've got something called the PESI calculator where you can work it out. And again, if you're used to dealing with coronaries, if someone comes into your cath lab with a coronary problem, and they have a preserved blood pressure, what's the mortality? 0.1%, 0.5%. Look at these mortalities. These are terrible. And it isn't difficult to get PESI class 4, and lots of patients get PESI class 5. So this is the standard of care on anticoagulation with bailout lytic. It's terrible. We need new treatments. Here's another way of calculating it. If you have a systolic blood pressure over 100, your troponin is up, your RV is dysfunctional, but you're tachycardic, your chances of having PE-related complications, which are death from PE, hemodynamic collapse, or recurrent PE at 30 days is 42%. 42%, this is happening in your hospitals. And then even if you get them through this condition, this sort of Cinderella condition that exists around the hospital, you sort of know it's there, but nobody really takes charge and manages it. If you get them through it, these patients aren't right. If someone comes through the door in my clinic and they've been medically managed with a PE, they're frequently more symptomatic than if they've had a myocardial infarction that had primary PCI. They're just not right. They have breathlessness, fatigue, recurrent chest pain, dizziness, syncope, and they have profound psychological disturbance, some of these patients, because they sat in a bed with a tachycardia for 10 days, which is bad for them on every level. So why do we need new treatment options in pulmonary embolism? Because the mortality is too high and because the morbidity is too high. Up to half of all PE patients have residual impairment. So today we're going to talk about one of the options that's undergoing a rigorous research program and is now in clinical use. And we're going to see some cases, and we're going to talk about some cases and try and work out, is there a new way to treat this dreadfully managed disease? Thanks. Okay. So I'm now going to invite Grzegorz Kopecz from Krakow. He's a world-class researcher. If you want to include people in your study, this is the man. He's going to talk to us about intermediate high-risk PE.
Hello, I will present our patient, the case of our patient who is 67-year-old male. He was admitted to the emergency department at 8 p.m. At our hospital due to progressive dyspnea starting about 12 hours ago. He had a history of cancer, currently treated. On examination, he had sinus tachycardia, normal blood pressure, low saturation despite oxygen supplementation, tachypnoea, and anxiety. NT-proBNP level was very high, and troponin was also increased. You can look at this ECG to see the typical signs of acute pulmonary embolism, for example, S1Q3T3 pattern or negative T waves from V1 to V3. Imaging is quite typical for severe patient with acute pulmonary embolism. You can see a saddle thrombus and large bilateral clots. What we usually look at when assessing computed tomography is the right ventricle, which is large and much larger than the left ventricle, which means that there is dysfunction of this part of the heart. Based on laboratory data, imaging, and especially clinical status, the patient was assigned an intermediate high risk according to the classification of the European Society of Cardiology. As per guidelines, we started anticoagulation with unfractionated heparin and monitored the patient strictly. We planned the complex assessment 12 hours afterwards. And 12 hours after treatment, the patient had a complaint of increasing dyspnea, increasing anxiety. He said that no symptoms improved. NT-proBNP level was rising, and we observed also an increased level of lactates. This is his echo, which is very typical with very large right ventricular right atrium and small left-sided heart. This is the end of part one.
Okay, Grzegorz, thanks. So I'm delighted to be joined by Ibtal Alamri, who's an interventional cardiologist from Leiden in the Netherlands, and by Jay Matthews from the Manatee Hospital in Florida. They both got extensive experience with pulmonary embolism and its various mechanisms of management. So I'll start with Ibtal. So what are your first observations of this patient? Can you estimate their risk of death or hemodynamic collapse on this admission? And what are you thinking when you see these data and you see this echo?
So, of course, this patient is classified as an intermediate high-risk patient, but when we see all the images, we all think this could be a high-risk patient or could deteriorate to a high-risk patient. You have involvement of the right ventricle, so he's in the spiral of death of maybe a failure of the right ventricle. And there's a high burden of thrombus. We go with the guidelines, we start anticoagulation, but this is a patient that I would really strictly monitor.
And Jay, we know things are probably a bit further ahead in America than they are in Europe in terms of the adoption of new techniques. This patient comes into your hospital. How quickly do you escalate therapies? And would you escalate therapies already in this case? This was 12 hours that you saw that climb in lactate?
Yeah, so when you have high lactates, have obviously a very poor prognostic sign, and these patients are the ones that have the highest mortality. These are the patients that we would actually treat right away. Our PERT team, will respond even within an hour of a presentation of a patient like this, especially if you have those echo images. That's a patient that's got RV dysfunction. It's you're going to be on the spectrum for cardiovascular collapse if you wait too long, and I think the mortality goes up. So we tend to treat these people pretty quickly.
So Gregos, what risk did you estimate at this point from this? We've got tachycardia, we've got low normal blood pressure, we've got hypoxia, we've got a rising lactate, we've got severe right ventricular dysfunction. Remember, 2/3 of right ventricular dysfunction is in the long axis. There's virtually no long axis function here, as well as radial dysfunction.
So usually after 12 hours, the patient improves. Yeah. And in this situation, there was no improvement. So I think that the risk is very high. Maybe not as in the shock, because he's not yet in the full shock, but he's quite near.
Lactate's going up, right? Yeah. I mean, we've got failure of end organ perfusion. So tell us what you did.
Okay, so this patient was quite severe, so he demanded consultation with PERT. There were the following messages based on the history: no clinical laboratory and cardiographic improvement despite 12 hours anticoagulation, increasing anxiety and dyspnea, and increasing lactate levels despite normal blood pressure. So we had 12 hours from starting the treatment of this patient. But we need to acknowledge that the consensus statement of the ESC experts show that we should think of reperfusion therapy only after 24 to 48 hours after anticoagulation. In this situation, the impression of the physicians and of the PERT team was that the patient was developing normotensive shock, which means that he had normal pressure, but probably very low cardiac output because the lactate level increased. So the decision was immediate transcatheter embolectomy. So we are at hour 14 from the diagnosis, 26 from symptoms. We are doing the procedure with very good effect. I won't put it in detail here due to some time frames, but you can see some effects of our work with penumbral lightning 12 system. Both lower lobe arteries have been reperfused. What we were able to remove, you can see also from the pulmonary artery. You can see also on the slide. The patient presented clinical improvement. Next morning, he had normal. He didn't have anxiety. He didn't suffer any dyspnea. Had normal saturation. We observed a decline in troponin level, NT-proBNP, and lactates went to normal. He was discharged from our hospital 72 hours after the diagnosis, or 84 hours from symptoms. Of course, on oral anticoagulation, with the recommendation to go to the ambulatory clinic, usually we send such patients to cardiologists. So we established the visit in the cardiology ambulatory after 3 months. Thank you.
So from heading to ITU, went home at 3 days.
Yes.
Needed a day to get the home ready.
That's great. This is what we want.
Yeah, exactly. Come and join us. We'll do a bigger discussion at the end. So now I'm going to invite Ibtihal to present another case. This one will focus on a similarly sick patient, but with slightly different parameters. So Abtal, take it away.
So good afternoon all. For the high-risk patient, I brought with you today a case of a patient of 84 years old, a female, with a history of hypertension, which was not treated, and a recent admission in the hospital due to intracranial bleeding. She presented at our emergency department after a hemodynamic collapse, for which she was resuscitated at home shortly. But when we saw her, she was already awake in a maximal EMV status. What you can appreciate from all the values is that she was a little bit hypotensive we know her with hypertension. She was a bit tachycardic. She needed a lot of oxygen suppletion to keep her saturated with a high respiratory rate. And there were already signs of organic hyperperfusion with a high lactate. So CT scan was performed and the diagnosis of pulmonary embolism was confirmed with a high thrombus burden, and you can already see that there was also dilatation and signs of failure of the right ventricle. So she was considered as being a high-risk pulmonary embolism patient, and according by the admitting doctor, and accordingly the PER team, or as we call it, the alert team, was activated. So this is a multidisciplinary team at our hospital consisting of an interventional cardiologist, but also of intensivists, thoracic surgeons, and vascular internists who are available for discussion 24/7 on site at the bedside of the patient during office hours and online during out of office hours. And the main goal for these multidisciplinary meetings are to define a treatment plan for the specific patient using this this protocol that we have in the hospital. And before continuing and discussing what we did with the patient, I'm of course curious about the meaning of the panel.
Thanks, Abtal. So Gregos, the prior patient, there might be one or two people in the audience who are thinking, why not just give systemic thrombolysis? It's clearly not an option here. Do you still use systemic thrombolysis? And why didn't you use it in the prior patient? And where would this patient fit in your algorithm?
So, in fact, our patient did not have any contraindications to systemic thrombolysis, but as most of you know, that thrombolysis is associated with risk of intracranial hemorrhage. It is not always always successful. And what we see from the different registries, generally doctors do not like fibrinolysis if they have anything else. So in our hospital, in which we have any kind of treatment available of pulmonary embolism, we generally do not use thrombolysis, outside local thrombolysis, of course.
You still give catheter lysis, but you just don't give systemic lysis.
Yes, per catheter lysis.
Yeah, and Jay, this one's heading for catheters, really. They don't have many other options. They're, again, rising lactate, right ventricular failure, much less reserve at 84 years old, as very, very high bleeding risk, even on anticoagulation. You know, this is a patient that could face anticoagulation interruption, never mind complications from lytic. So again, where does lysis fit in your pathway, in your cascade? And does this patient go straight to the lab? They're 84. Do you take an age differentiated approach? Are the complication rates higher in the elderly? What would you do?
I work in Florida, so everyone's old. So 84 is middle age. You know, we've even taken patients over 100 to the cath lab, and it all depends on the safety of the devices, right? And so lysis, of course, is associated with higher risk in the older population. Of course, it's dose dependent. This patient's got absolute contraindications to lysis. I would not do lysis here. And could you get away with it? Maybe, but then you also potentially run the risk of rebleeding within the previous infarct bed. I would do catheter-based thrombolysis here, but you have to be careful in your catheter choices. We'll talk about that a little bit later. I think some of the devices have better safety profiles than others, and so if a patient is very sick, if you take a really large device through their right heart, then you risk compromising the ventricle. So I think it's very important in the catheter choice when it comes to doing these kind of patients.
So you would preferentially choose catheter lysis over thrombectomy?
No, a catheter-based thrombectomy device, not CDT.
Okay, sorry. So you would go for thrombectomy straight?
Yes.
Just out of interest, who has a thrombectomy device available for pulmonary embolism in their hospital? And who is able to refer to another hospital? So hands up if you have none of these devices available to your patients. Okay, so there's enthusiasts here. So Ibtal, there's a lot of enthusiasts in the room. Maybe they'd do the same. What would
Yes,
you do?
so indeed, because of the contraindication for the systemic thrombolysis, we proceeded and performed catheter-directed mechanical thrombectomy using the CAT12 system. As you can appreciate here, we bring in a long 14 French sheath up until the pulmonary artery. We make an angiography to guide the procedure, and afterwards we proceeded with the thrombectomy. Of course, when treating high-risk pulmonary embolism patients, we always say you have to really be aware of and prepared for hemodynamic deterioration of the patient, especially when you bring in your devices and stretch your right ventricle. That's exactly the moment when the patient can hemodynamically collapse. So make sure you're ready to, and your team is equipped to treat these patients and provide mechanical support when needed. So always a discussion when to end the procedure. Should we take out as much clot as possible, or what should we do? In lack of any evidence for that, we guide our procedures based on the hemodynamic parameters of the patient. And of course, taking into account to limit the blood loss. So if we go back to our patient, then we can see we took out a sufficient amount of blood clot, but we can see that her blood pressure improved significantly. She didn't need any oxygen suppletion, and her lactate went down. And as said before, even regular anticoagulation would be a potential problem for this patient, so she also got a VCI filter to treat her better. 24 hours of observation at the ICU, she could be discharged to the regular ward and afterwards went back home in a very good condition. So in conclusion, your model of the pulmonary embolism response team is really essential, so that you make sure that you have a patient-tailored approach for every patient you face. The multidisciplinary collaboration ensures that you can really effectively include and use the new techniques that are coming available time by time. Make sure that your team is equipped and trained to treat hemodynamic collapse in these high-risk patients, and use your hemodynamic parameters to guide your treatment. Thank you for your attention.
That's great, Ibtal. So the patient never went into shock in terms of a low blood pressure, but they had evidence of shock with a rising lactate. And this is an important concept, that patients can vasoconstrict and vasoconstrict and vasoconstrict, so they can manage to generate a blood pressure of 100, but they have failure of end-organ perfusion. That's the definition of shock. And what happens is they just go off a cliff, and they go off very suddenly. So it's important to understand that when you see that rising lactate, it predicts a 7-fold odds ratio of death. And it's because that is when they're decompensating. And we've seen that in both these two cases. What we're going to do, to make sure we don't run out of time, we're going to go on to Jay, and then we're going to just amalgamate the discussions at the end. So Jay's going to talk to us about some data and the research program that's evolving with the Penumbra devices.
All right, I'm Jay Matthews. I have the pleasure to be involved with multiple thrombectomy devices that have come to the market or coming to the market. Also a number of other technologies as well. I'd like to talk a little bit about some of the data that we've generated from the Indigo system. Strike-P was a real-world study utilizing the new Lightning Flash system, which is still pending to come to Europe, and then also the Lightning 12. Looking at real-world metrics, the PI of this was Dr. Moriarty out of UCLA, 55 global sites, 600 patients. I think there are some people here who are also involved in the study as well. Looking at the composite MAE at 48 hours, and also looking at RV to LV ratio change at 48 hours, which is a pretty standard metric. And secondary endpoints also include quality of life and functional outcomes out to 90 days, and also long-term follow-up out to 1 year. So this was an interim analysis that was presented, and this has been published in JVIR. It showed a significant improvement in RV-LV ratio down to 25%, improvement in PA pressure around 9%, and also multiple symptomatic improvements as well too, the EQ-VAS, Borg scale improvement. Thrombectomy time on average was around 33 minutes. MAE was very, very low at 2.7%. Quality of life improvements again seen, sustained out to 90 days. And so this obviously supports the use of this technology within this space. But ultimately, The issue with a lot of these data sets is that it is, it's not randomized. And so as a result, STORM is one of several randomized trials that are currently ongoing as well too. That's going to be really important in proving that mechanical thrombectomy is highly effective for this patient population. It's looking at the patients with INRI to high-risk PE, comparing a mechanical aspiration to thrombectomy with anticoagulation versus anticoagulation alone. And Dr. Rosowski and Dr. Lukstein are both the co-PIs of this global study, 25 global sites, 100 patients. With acute to in-risk high PE, and looking at RV to LV ratio change at 48 hours, also looking at MAE at 7 days, and quality of life and functional improvements out to 90 days, and following these patients out to 90 days. So this study is ongoing, and we look forward to the data that comes out of this study. So I'd like to show you our PERT algorithm. I've been involved with the PERT program, and I'm the PERT director of our institution for the last 10 years, and it's evolved over that time period. For patients with submassive PE, we have a lot of options available, but I'd like to highlight the high-risk patients. And we know that patients with elevated PA pressures are the ones that are at highest risk. And so those patients, as I made a comment regarding device selection for mechanical thrombectomy, it's very important. When you start looking at the number of large bore thrombectomy devices that are coming to market, some of them have very stiffness and whatnot too that can potentially compromise the right ventricle. So when we have a patient that has a very high PA pressure, we do a right heart catheterization on the table to help decide what device we're going to use. So we choose based on the patient and also their hemodynamics as well too. You also may decide whether or not the patient needs ECMO as well too at that time to help make the procedure easier. And so patients with high PA pressures in general, we tend to use more Lightning 12 and flash. And don't forget, some of these patients that are stable potentially can get CDT as well, because that's a very small bore type device. Patients with low PA pressures, you can certainly choose a number of different devices, but location matters. And so for patients who have clot that's both central but also potentially peripheral and segmental, we like to utilize the flash system now as well as Lightning 12 to be able to get down into the more distal segments. Patients with primarily peripheral clot, though, CDT still seems probably the easiest way to do that. So the difference with computer-aided vacuum thrombectomy is that you're now able to utilize a computer-aided algorithm rather than just simple manual suction alone. And the flash system utilizes a dual clot detection algorithm, both pressure and flow, to be able to identify whether or not you're in thrombus or open vessel. So 2.0, which is what's going to come to Europe, we just recently started doing cases with this system, is actually a software upgrade for the algorithm that allows you to do these cases a lot more quickly, safely, less blood loss overall, and also it's a lot simpler, a lot less understanding of the visual cues, and I'll show that to you real quickly here. So this is 1.0 versus 2.0. In the past 1.0, there was a sampling mode, there was a clicking that you would get to tell that you were within clot, and then if there was occlusive thrombus within the catheter, it would go into this flash mode where you have a rapid cycling of the pressure and also increased blood loss as well too. They were able to simplify this down to the sampling mode and gallop mode. So now you just have a system where it's flashing green, you're an open vessel. The blood loss paradoxically is less than you see with Lightning 12. So even less blood loss, even with a larger bore catheter. The gallop mode is is when you're within thrombus. And so by switching back and forth, you're able to do these cases a lot more efficiently. If it goes red, that means you have air in the system. And I'll tell you that our case times have dropped dramatically. When we first started CAT 8 years ago, we were doing cases within an hour. And then when Lightning 12 launched, cases dropped down to about 30 to 40 minutes. With the flash technology, we're doing cases in as little as 5 to 7 minutes. So this is a remarkable improvement. In fact, overall case time, 10 minutes from start to finish. So this is a dramatic improvement. Once you have the algorithm down, you're able to do these cases very quickly. In fact, I did a case right before I came to this meeting. So this is an 85-year-old gentleman with COVID, 3 days of progressive symptoms, severe hypoxemia. He's got all the usual risk factors. Heart rate is high. Systolic blood pressure is low, but not on vasopressors. Oxygen saturation is low on 6 liters of nasal cannula. Initial PA pressure is a little bit elevated at 45 millimeters of mercury. Lactate is 6. So this is a patient that is that normotensive shock type patient. I always do a venogram on both sides, and there's clot in the iliofemoral segment. So the first thing we did to avoid embolizing the clot is to aspirate first with the flash system prior to advancing the large bore dry seal sheath up into the iliocaval junction. So this is the CT scan. You can see that there is a large saddle pulmonary embolism extending down to the right and left sides. Here's a coronal view as well, too. You can see extensive clot in the left upper, middle, and lower lobar pulmonary arteries, and also extending on the right side as well, too, up to the truncus, right middle lobe, and right lower lobe. And so you can see this is our initial image. You can see there's a fair amount of thrombus there, proximally and also distally. You can see that we can advance the catheter without a wire. This is unique to the catheter because it's very soft and atraumatic. So I always get 2 access points. I have a pigtail catheter up that allows me to get pressure simultaneously to be able to do injections as well. So I'm able to puff with a little bit of contrast to be able to direct my catheter down. You can also do your pulmonary angiograms this way. So with only 5 cc's of contrast with 50-50 saline contrast mix under digital subtraction angiography. If you do a breath hold, it's quite nice for visualization. So we're able to take another picture here. You can see that we've cleared out the proximal thrombus, but we still have clot distally. Again, able to direct the catheter down very distally, even without a wire. You can certainly use a wire that comes with a select catheter to help guide down distally if necessary. After this, we've pretty much cleared out everything. Switch over to the other side. You're able to use the H-torque curve. That's a curve that comes with the catheter. Able to flip over to the other side very easily. We also take our imaging catheter over to this side as well. You can see there's extensive thrombus in that interlobal branch, also extending into the middle and lower lobar pulmonary arteries, and also in the right upper as well. And so here we easily are able to torque it up into the upper and then also go down into the middle and lower lobar pulmonary arteries. And after this really just took a few seconds, cleared everything out with just really one pass. So this is what we removed, and you can see that the PA pressure has dropped dramatically, cut in half, essentially normal. Oxygen saturation normalized onto room air, and there was a large iliofemoral thrombus that we removed the next day via a contralateral approach. Thank you.
Okay, that's the future. So just to reiterate, the Cat8 was the one that we used in extract PE, and that was quite a small catheter. It wasn't designed to do pulmonary embolism, but it was used for pulmonary embolism. The Lightning 12 is a 12 French device that's available in Europe now, and that's what we're using to date in Strike PE. But I recently presented at the Charing Cross Symposium the first 43 patients who'd used the new 16 French Flash device. So the Flash device that Jay showed is 16 French, and it has a dynamic algorithm that changes the suction pressure to try and loosen up the clot so you can then get it. So that's the key difference. That's coming to Europe, we think, in 2 or 3 months' time. I'm trying not to look over here to find out the exact date, but it'll be about 2 or 3 months' time with a bit of luck. And then that's the one that will be rolled out across Europe. Ibthal. So there's a number of strategies we can take for a patient who has intermediate high-risk pulmonary embolism. Let's focus on those. Their blood pressure is preserved, and let's face it, the majority of them survive. You know, I talked about poor mortalities, but in the intermediate high-risk group, it's somewhere between 4% and 20%, depending upon how close they are to this line of normotensive shock that you showed. So in your center, they are started on anticoagulation, and then you see how they go before you make a decision on the other devices. Is that how you handle them all?
Yes, that's how we handle all the intermediate high-risk patients, actually. But we, beforehand, when the PERT team comes together, we already decide how many time we're going to take or when we do the re-evaluation. Because I think one of the most important things is to realize that lack of improvement is also considered treatment failure. So most of the times when you just leave your patient at the ward, you call and you ask how is the patient going, and they say, oh, he's stable. But that means if he's stable, not improving, then that's a treatment failure. And these are the patients that we would consider for mechanical thrombectomy.
It is. Are you able just to turn this microphone on? Can you just turn this microphone on, please? There is a substantial amount of psychological disturbance that patients experience when they're in hospital sick for a long time with pulmonary embolism. This is now proven. It's part of the post-PE syndrome. And leaving patients for a long time on the edge of cardiovascular collapse can be not just physically damaging to them, but psychologically damaging as well. And I noticed that, Gregos, you intervened earlier. You did an assessment at 12 hours. You talked about the European consensus statement that we wrote. But you're going in a bit earlier than the standard European approach. So is that highly selective? Is that 20, 30% of the intermediate high-risk patients? What proportion are you going in early like you did in this case?
So we think that the 24 hours to 48 hours time is quite arbitrary. We do not have good data that it just should be as long. So in many cases we do not wait so long. It is due to several things. The first thing is the patient quality of life, let's say, during the acute syndrome, because the patient who I described today, he had severe anxiety, and we weren't able to do anything with that, with this anxiety, and he needed to be operated just now. So this is the first thing. The second thing is that we do not like to do the procedure when the patient is in shock or has cardiac arrest. Nobody likes it. So it's better for us to make any decision and to do the procedure when he's still stable. And the third thing is the thrombus. If you wait too much, we may not have good enough results because it is the best situation when the thrombus is fresh because it's readily removable, easily removable.
And that's a good point, is by following the guidelines, we make thrombectomy harder because the clot becomes wall adherent over time. Jay, I noticed you've still got catheterlysis in your algorithm. Is it selection by operator as much as selection by patient, or is it really an algorithmic approach like you've shown there?
Yeah, I think that mechanical thrombectomy has largely taken over most of our practices for every person that's on the PERT team. Because, bed availability is an issue as well, too. These patients who get lysis even if you do the lower optimized protocols, you still have to send them up to a monitored environment like the intensive care unit. So it's a resource utilization issue as well, even though it is relatively safe, and some of the recent data shows that it's, the bleeding risk is relatively low in the right patients. But I think CDT still has a role for some of these, potentially sicker patients that can't tolerate any type of device and whatnot too. So I think I would be remiss not to mention that still has a role even in the modern era, even though a lot of these fancy devices are out there and we get some fantastic looking results.
Yeah, I see pulmonary embolism as a bit like calcium management, that you're not going to use one in PCI. You're not going to use one device for all coronary calcium. You're going to have a range. And I think having thrombectomy and lysis on the shelf, I think it's important to have both available.
You may use both too, right?
Yeah.
If you have still a lot of peripheral obstruction, Seattle 3D did show that prediction of RV recovery was dependent on the distal perfusion, not the proximal central obstruction. So, you may clear out the proximal stuff, but if you still have poor perfusion distally on your on-table angiograms, using adjunctive lysis may still be useful.
Yeah. So, Abdal, this is a very different sort of patient. So we're used to cardiogenic shock. A lot of us trained on coronaries long before we trained on pulmonary embolism. And yes, we know what to expect from a cardiogenic shock following anterior STEMI. They may or may not need ventilation. They certainly need vasopressor support while you're getting on with the procedure, and then they get a device to support them. When people start thrombectomy programs, they're going to be faced with patients where it's a bit ill-defined as to what to do with them. Should you put them on ECMO? Do you wait and get lines and get vasopressors on? Do you go straight in? So how do you handle the patient in shock? What's step A, B, C in your center?
I think when the patient is really in shock, when it's very clear that the patient is in shock, then we would always proceed first with putting the patient on mechanical support before continuing and doing our thrombectomy or whatever procedure we want to do. Because as I said before, when using your devices inside the heart and you stretch the right ventricle, if you already have a patient that's on the edge of deteriorating, you know for sure he's going to collapse, and you will need to put in the ECMO in the acute setting. So to prevent that, it's better to do that in a stable manner, let's say. So if the patient is in between, like it's not a shock yet, but you're in doubt, I think it depends on your experience. If you're in our hospital, we are very, very experienced in putting patients on mechanical support. So when we want to put a patient on ECMO, it's done in less than 5 minutes. So in that case, and you can say, okay, we have time to wait, because if it's needed, then the ECMO is in there as soon as possible. But if you need a surgeon or something else and you really need time to put in the ECMO, then just try to do it on beforehand before continuing to do the thrombectomy, I would say.
And you're delivering the ECMO percutaneously as interventional
Yes,
cardiologist. I think that's one of the key things in Leiden.
Yes.
So Gregos, you presumably have ECMO available. Do you implant it yourself, or do you have to call a team to do it? If so, do you go up front? What would you recommend for centres that don't have ECMO if they've got an unstable patient?
So it's a big problem when you do not have ECMO. So we in Poland, we underuse ECMO in pulmonary embolism yet. Our anesthesiologists are not so convinced about it, but we we discuss with them, educate them. So I hope it will change. So if we have a patient with in shock, we start with noradrenaline, dobutamine at first, and take that patient very quickly to hemodynamics and do embolectomy, because it is usually we do not have time for lysis, catheter-based lysis or just systemic lysis. If you do not have ECMO in your center, you just should phone to the PERT and to ask the PERT for help, because probably in some hospitals nearby they have ECMO. And until you have such support, you need to use high doses of noradrenaline or dobutamine usually. And oxygen, of course, 100% oxygen.
Yeah, I mean, Jay, these are sick patients. We don't want to scare people off, because they're a small number, aren't they? About 5% of patients with pulmonary embolism are shock. Maybe 15 to 20% of this intermediate high-risk group who aren't in shock. So how would you recommend people start their programs? What cases are you looking for to get going?
Right. I mean, it may be attractive to go after the sickest patients, but the highest mortality will occur in that scenario, and then your program will shut down. So you need to have success. So in general, I would focus on the intermediate risk patients primarily, work your way up to the higher risk patients. And then ultimately, when you have an established program, that's when you start dealing with the more questionable patients, which would be the highest risk patients, the massive patients as well. You need to have a good infrastructure to be able to go after those patients. But you want to have successes in the beginning in order to be able to have a good program.
I would agree with that. I think you want to go with people with reasonably elevated bleeding risk, who you would have concerns about systemic lysis, but who have intermediate high risk. Maybe their blood pressure is 120, 130, their heart rate's 120. That's a good combination of parameters that you can start programs with patients like this. We can all see they're sick. They've got bleeding risks, so systemic lysis is not a great bailout if you're going to use it at all. But they're not so sick that you get into trouble on the table. Right, we've got 1 minute left, so I'll very quickly pull up my last slide and close. So thank you for coming, everybody. Next steps. This is just the beginning. I mean, it is really a golden era for clinical trials in this area. There's 4 or 5 major outcomes studies that are ongoing at the moment, and they're recruiting in Europe and America and around the world. It will be a body of evidence that defines for a generation how we use these technologies in the cath lab. We have Storm PE and Strike PE for Penumbra, so congratulations to Penumbra for investing in science. One note, if you set up a PE intervention service, you will get referrals. This isn't like the coronary sinus reducer or even one of my baby's renal denervation, where you have to look hard for the patients. If you set up a service and you advertise it, you'll get phone calls day and night, every day of the year, as we all know. This is a growing specialty that has got high demand. But I would just reinforce, start with those who are at intermediate high risk and then build up and build out. And if you want to see some more data on this technology, come along on Thursday. I think it's this room at 5:15 if you want to see some more from Strike. So thanks to my panel and thank you all for coming. Thanks.